Hi, your medical director doing cot-side chats by Dr. R. And today we've just been trying to ventilate this patient, and we have been unsuccessful with our bag valve mask technique. And so we're going to need to find some better way to ventilate the patient. Now for the paramedic level, we're going to be looking at intubation. And now we're not doing rapid sequence intubation, but we do have times that we do need to intubate in the field. So with that, if possible, we'd like to try to hyperventilate the patient prior to the intubation attempt, but sometimes we have just not been ventilating well, and that's why we have to move on. So with that, we're going to move these things over. And let me just cover some of the stuff that we're going to want to make sure that we have available. I think one of the biggest things we need is suction. There's always going to be secretions in that airway. So let's make sure we have good suction to be able to get as much of that material out of there to make it easier to visualize. The other things we want to make sure we have are endotracheal tube. Typically a 7 or 7.5 in a female, 8, 8.5 in a male are the appropriate size. Personally, I like to have the stylet to go with it. It just makes it a little easier to get the tube to go where we want. It does a couple of things actually. If we slide the stylet in, okay, number one, we want to make sure it doesn't go down outside the end of the endotracheal tube because we don't want to be damaging anyone with this. Now, and then we can obviously do a little bit of manipulation with it. And the other thing that it does a little bit of benefit is it keeps your adapter from coming off. I have had occasions where if I did not have that on, I would get the patient intubated and then the adapter will have come off and you're having to hunt around for that. So this helps to keep the adapter on as well. We also need to have our syringe and check and make sure that our cuff inflates prior to intubation and that it holds its inflation. And we need to have this handy. Now, if it doesn't bother you, some people it's annoying and they don't like to have it on their endotracheal tube during the intubation. With that, I'll put it in a side pocket or I'll hand it to my associate and have them hold on to it. But I don't like to have it just flopping around on the bed because you won't be able to find it when you need it. I think, and then the other thing that we need, you need some way to show that you are actually in the airway once the intubation is done. Just listening to breath sounds bilaterally, while it is very good, that is not enough. We need some kind of secondary diagnosis. And I think the end-tidal CO2 is a very good way to go about this. It should change color, turn to yellow during exhalation to show that you are in the trachea and not in the esophagus. And then that needs to be documented that you also saw that with your intubation. Now, when it comes to the blade itself, that's a personal preference. A lot of people like the Mac blade, which is curved. This one, as we recall, does not actually lift up the epiglottis. It goes into the area called the vallecula between the epiglottis and the tongue. And so when you lift with this, you still will be seeing the epiglottis. A lot of the anesthesia people and people who do intubations frequently like this one. I think it's okay, but I still typically use the Miller. And a Miller 2 is going to be big enough for the vast majority of adults. When you start getting into like the Miller 4, it's so big that it takes up a lot of the airway room. Now with this, you get a direct visualization. So now then this actually lifts up the epiglottis so that you're seeing the cords directly. You still can see the cords when you use the Mac, but the epiglottis will also be able to be visualized. So we need to make sure all that's working. Now when it comes to the technique of the intubation itself, we again want that patient in the old sniffing position as much as possible. So they're like this. That way we're aligning the upper airway with the lower airway to try to make it easier to visualize while we're doing the intubation. Some people, it may be more difficult if you have an elderly lady that is like this. She has that hump. When you lay her down, she's going to be like this. So we may need to elevate her head with a pillow or towels to try to get her more in that sniffing position. The opposite of that is the small child who has a big head. And when they lay down, it goes like this. And so we may need to build up towels under their shoulders to get them in this position. But getting them in the right position does wonders for getting a good look. So now then we have our patient in the right position. We set them up. When we do our intubation with these, I like to have my tube handy, and again, if I have an assistant with me, I'll have them holding onto this. But then you go straight down, come down from the right side, and we're kind of pushing the tongue over. And it's not this, we're not cranking, we're lifting, okay? So we lift straight up, and what we hope to see are the cords. If you don't see the cords, you're not going to get lucky, you're not going to get them intubated, okay? You're going to put it in the esophagus and then hope. So we need to see the cords before we do this. I don't have any lube, so this may be a little harder, but let's see. So then we come in, and some people, it's okay to intubate with this directly like this. I like to bring it out to about a 45-degree angle so that when I'm advancing, I don't have my hands and such in the way. Let's see if I need that. Looky there. So now that we come straight down from the side, visualize the cords, just pass the cuff past the cords, and then come out. We want to inflate. We'll pull our stylet, make sure you hold, and then we will bag here. Now I still need to get my end-tidal CO2 on. We can see the lungs are inflating, and then we need to look at where we are at the lips here. We're at about 23 at the lips. That typically is going to be a fairly good location. If you get too deep, you're down at 27 or so. You're more likely to go into the right main stem, and then you will only be ventilating the right lung and not the left. So make sure you auscultate well when you do that. Now, I did not open this up with the end-tidal CO2. Goes on here, and again, we're looking for a color change to show that we are in the trachea. And I believe now then we'll just need to get our devices in place to hold it. You know, as we're going along, just make sure you have a good handhold on it so that we're protecting it until we're able to get that in place. So I believe that's it. I'll see you next time. This is Dr. R.